Hi, thank you for having me. So I want to talk today about sort of the big issue of how do we do this and how do we get it into clinics. Not so much about the applications that we build, but I'm a software developer and a designer. So these are two applications. One is Cool. So I worked for over a decade with Hunter Hoffman and the team from University of Washington. So Cool is sort of a next generation snow world. And it's a first person, we're playing paintball with otters up there. And on the right, we have an application called Glow, which is sort of an extension. So we've also collaborated with Diane Grimala for many years, did the things like the virtual meditative walk, which she talked about. Glow is sort of an extension of that. It uses a leap motion, hand interactions, biofeedback sensors, and used for acute and chronic pain. So all of these are used in hospitals and clinics right now. I want to talk about a specific, use a case study from Providence Cancer Center in Portland. This is Dr. Shorin Nemeth. He's the head of pain medicine there. I'm going to let Shorin speak for himself, but we did a study working with pancreatic cancer patients, and we have a little video, so, and this also shows some footage of what our applications look like.
We know that pain is a perception in our brain, and it's made up of different components. The emotions that we're feeling at the time, our psychosocial circumstances, all those things can change our perception of pain. Part of why I decided to conduct the virtual reality pain management clinical trial here at Providence Child's Cancer Center was that it took what we know about treating pain and pain medicine and put it into practice. What virtual reality does is it hijacks the brain, if you will. It takes your mind off of the pain and shows your mind that it can do something else, brings it to a different world, allows you to have a different experience. So this study was a pilot study, and the design of the study was just to see if there is a trend towards meaningful clinical impact with virtual reality. We looked at a lot of different things in the hardware as well as the software that we evaluated. If we're going to test the technology, we want to test the technology in the best current state, the best graphic resolution. We wanted the most robust experience. The more processing of the brain that we can harness, then the more likely we will be to decrease that patient's pain. That means we want auditory stimulation, so we want some type of music. We want visual stimulation. We also want, if we can, some type of tactile or movement sensation. Based off what we saw in the pilot, the potential is there. The potential is there for pain relief, for opioid reduction, and for cost savings measures. We did show 30% reduction in pain, about 20% reduction in opioid utilization, and we did show significant cost savings. About 70% of the patients said they would use it again. To summarize, what we looked for in the pilot was the best possible version of virtual reality available for the medical setting. I think all of those experiences have really influenced my approach toward pain management and also led me into the idea that maybe virtual reality would be a very helpful tool for a specific subset of patients.
Okay, so those were compared to historical data. So the numbers that he's giving, 30% pain reduction is not just sort of a baseline that's better than standard of practice. So this is an example of what that system looks like. It's sitting in a bedside. One of the real challenges of doing this was that they contacted us and they said they wanted it sitting bedside with these patients for 24/7, that they could use it anytime they want on demand. And to my knowledge, we had never done that, I don't know of anybody else who's done that. Really just give it to them in the hospital and let them do it. So we learned a lot, and there were a lot of lessons from just the outcomes and also the process of doing that, which I want to share. Providence Cancer Center, they had 29 people completed the surgery or it completed the procedure. So pain, opioids, cost savings, and I think it's really significant we had no side effects. So when Dr. Nemeth talks about they wanted to test the best possible sort of use of technology or the best possible implementation of VR, it's not just the software, it's the entire system. So I want to use a framework that I've developed, which is to really think about this in a comprehensive way. So I'm a developer, and I kind of, I've been doing this for many years, and there's a big difference between me going into a hospital and setting them up and training them and teaching them. And sort of put a point on it, where we need to be is to make this a mature technology, is I need to be able to sell it to these people over here who put SKUs on it and put the whole thing and kit it up and put it in a box and then send it over to these people over here, and hopefully those people will train these people and really do this at scale. We're talking about hundreds of thousands, millions of units, and I can't do that. So in order to do that, and to think about this in a comprehensive way, I've borrowed this from NASA, which is NASA has, of course, a very sophisticated way of determining whether a technology or any kind of solution is, quote, mature. And of course, their stakes are very high, and I think in healthcare, our stakes are high too. So it starts with technology. You have to have an effective intervention. We have an effective intervention. We proved that with Snow World many years ago. We knew that, but there's a huge gap between that and millions of people using this as a solution. So effective software and the hardware platform to deliver it, that's something I'll talk about. Programmatic changes, so that's a clearly identified user, and with the implementation and financial models to build and sustain that enterprise. And in terms of the developer, it's not just the ability for me to develop Cool and Glow, it's the ability for me to develop, deliver, and support that at scale. And NASA, incidentally, also includes manufacturing in this, so that kind of gets to our tech partners over there. And in terms of the customer dimension, it needs to, the providers and the patients maybe themselves have to have they need to want the solution, and they need to have the ability to get that and to use it easily. So starting with technology, I think it's always good to look back at where we were. That is, in fact, my mother, and this is from 1995. And at the HIT lab at the University of Washington, where I started. This is a terrible headset. This thing weighs 7.5 pounds, and we used to put this on kids' heads. I started, and we took these out into schools, and their first experience of VR, we put it on a little kid's head, and their first experience of VR is like this. And they're hunting sharks with a net. And, but they liked it. They were happy. But anyway, you can clearly see that that's not a mature technology. The implementation that we did was, it's shown here. So it starts with, we used a Vive headset. Thank you, HTC. We used a Scosche heart rate monitor. It attaches to the wrist. An HP workstation. Thank you, HP. And a touchscreen monitor. And so we, and it's all on a cart, so it looks like some piece of, it fits in that environment for medical equipment. We also built because the patients were going to be using this by themselves, we built with a touch screen so they didn't have to screw around with a mouse and all that. And we did a co-branded sort of launcher with big buttons, so it's like, I want this, I want that. That was very effective, and they were able to use it. So in terms of the technology dimension, the software and the ability to deliver it, we're happy to say that our software has consistently, for a very difficult pain population, had a very effective outcome. And over 70% of this older set, pancreatic cancer patients tend to be much older, 70% of them wanted to do more VR. So triumphs of the hardware. building these systems, we have mobile applications and all of that, but I think there's really a lot of value in mirroring and having that other screen, because VR is, in a good sense, it's isolating. It occludes the rest of the world, so I'm not sitting there thinking about the nurse working on me, et cetera. But it also cuts me off from my social interactions with my family, with the nurse, with the therapist, and if you have a mirrored on our touchscreen, you can see what the patient is seeing, so the therapist can work with them, the family can partake, and that sort of social interaction, I think, is a very important component we don't want to lose. Our launcher, we talked about, really important. So we used a desktop machine. You can use a laptop, of course. We do that quite often. But when it's sitting bedside, noise is a huge factor in the hospital environment. Like, nobody wants to be sitting there recuperating with a fan going. So we used a really good desktop, and it was absolutely quiet, which we were very happy about, and I think that we saw great results with the performance. The other thing is it's always on. So anything you have to charge is going to add labor, it's going to add thought, it's going to, oops, I didn't charge it and I can't use it. So we wanted something that was always on, 24/7, they could pick up and use. Silent computers are golden. And then some challenges. You come across all this logistics stuff, because when you leave it in the room, all sorts of things happen. Security, locking, where you're going to store the equipment when it's not being used. What if Johnny goes over there and gets in and starts to surf the web? All sorts of stuff. Sterilization, of course, is a big deal. In this case, the patients were using it repeatedly for over a period of time, so they didn't have to sterilize it necessarily between uses. Wireless is great. Everybody loves wireless. Of course, we want everything smaller, lighter, cheaper, faster. But in terms of wireless, we're almost there, I would say. The technology works. Does it work well enough to be in a hospital and consistent every time? We're almost there. But I think the future that we're going towards is a really cool, like in these therapeutic environments, is a really nice high-powered machine that's off in a closet that is just sending the video signal to the headset. And the reality of trying to do all of the processing on your face, is going to be we're going to be in a different world that's streamed from the computer. Oh yes, and consumer devices are not really always that great for medical applications. So the programmatic dimensions, so VR is effective for many different populations. We've heard a lot of that. And we saw a big effect for this, they really picked out the worst pain population, the worst pain problem. So we're very happy that we got those kinds of outcomes. High acceptance, repeated, 20, 30 minutes. I want to share a quick little story that one of the patients that I was there to work with was an elderly woman, and she tried Cool. She was in there for about 30 minutes. We had to pull her out. She comes out and she goes, it was great. I felt like I had an otter on my lap, and I was shooting the otters, but it was out of love. And I was like, this is great. But then her longtime caregiver was standing in the back, and she comes up to me and she said, "This is a woman. I haven't seen this part of this woman. I haven't seen her act like that in years." And something about VR, I mean, we've heard about it, the fractured self and all of that. Something about VR kind of put all that back together in a way. But what that suggests to me is it really was a poignant moment, because number one, it shows how we're not really doing right by sort of the way we care for, let's just say, elders. We're not caring for people. Why is she in a condition where she's depressed and isolated? And that's sort of a call that we need to do something better. And the other is, why is healthcare I think VR has a lot of potential to help in this domain, but why are we? Healthcare has not been very responsive to those kinds of quality of life and other kinds of things. So we are seeing that. I think it's really important to iterate that. The implementation, provider training and buy-in are totally crucial. There was this interesting thing where we trained the doctors, we trained a cadre of nurses, but there are 70 nurses working on this floor, and different shifts, and you just can't get everybody in there for training. So training is actually a big sort of, big beginning to end. We've got to train everybody, we've got to get them to buy in, we've got to get them to actually, as you mentioned, offer VR as a solution instead of the drugs. And even though the nurses psychologically, sort of attitudinally, they bought into it, it's much easier to just come in and give them a pill and do the standard of care. So the doctors had to spend a lot of time going, no, really, you should be like encouraging them to use the VR system that's next to it. The other part of that is that people do not have the ingrained, we reach for our phone sort of reflexively, but we don't have that same sort of reflex to reach for VR. It's not like a piece of our lives and our sort of being in that way yet. And so, especially for these seniors, they weren't like, where's that VR thing? They had to be encouraged. And what that evolved into was basically building some sort of structure into their day, and the physical therapists actually getting them to engage with VR, and that really increased the uptake. So part of this is the budgetary and the financial aspect. So the ROI is proving out, which is good. We need more ROI studies, but this is a very good one. They got a very significant reduction in costs, which they're further investigating. Reimbursement is a requirement to scale. That's something that First Hand is working on right now. And a target for VR, there's this challenge. Hospital budgets, as probably many of you know, they take a year. You're planning a year out, or maybe 18 months. So even if I can get them I can get the hospital to make a commitment today, it's not going to happen until 18 months later, which is very difficult. Speed to market is so important for small, innovative companies, and especially when you're trying to go through the valley of death and bring innovations to market, that can be a real killer. And so it's a real challenge in the United States, where we have, every hospital system wants to do a pilot. Let's see how it works here at Providence. Let's see how it works at Kaiser. Let's see how it works. Hopefully we're going to hit the tipping point. The tipping point in medical technology tends to be 30% acquisition, or 30% use. After 30% of the people start to use it, then everybody starts to do it. So that's kind of our target. Sustainability, reduce friction of the end-to-end solution. There's too much friction even now. Even if I do go and set things up, just with all of the stuff you have to, the drivers and the this and that, and if Windows updates, it can get ugly. So we really need to have a frictionless system that has a lot less. I need to be able to build an executable for my VR application like Word. It's like if you had to run middleware to run Word, you go crazy. Enterprise VR application distribution, updates. So one note about security, the hospitals don't want your thing, your VR system. They're not happy if it's attached to the network. So all of our software is designed to run off the net and offline. And so that makes a challenge for actually sending them updates and doing things like that. So all of that has to be worked out. There are solutions for this, but it's something to think about when you're talking about an end-to-end solution. Developer dimension, that's my partner, Ari. I don't know what he's doing with his hands. Creation, validation is so important. And what we need to do is we need standards. We need a more of a comprehensive thing. So, once we can validate software healthcare is all based on consistency and known outcomes. And so we need to be able to do that at a scale that we can create applications and not go through a long IRB process for each one. The desire for more content is a Pandora's box. So what this means is that we're in kind of a Netflix bind. You ever go on Netflix and you're like, there's nothing to watch? I do. So if you're doing a study, and you kind of want to limit the confounds, right? So you don't want 10 applications because then you gotta, your matrix looks like it's crazy. So you want a limited number of applications. You want enough, and you want quality. And also from the practical implementation side, we don't want to have the doctor having to make choices and switch out their, what do you want to do? Here's your menu of 5 things. You want to put the thing on the screaming child's head, and you want it to work. So in terms of that, the desire for more, there's kind of that balance between the number of applications and creating too much choice. Delivery, we set up, deliver, train. We're working with partners like HP to do that at scale. And in terms of support, we were very happy that we had very little downtime, very little sort of technological issues with our cart-based system. So I'm just going to kind of breeze through this. I'm going to share my slides. But in terms of the customer, that's of course the customer is king. Structuring this into their patient's day, one thing that we found was that offering it 24/7 is not necessarily better. That if you can structure it and have a therapist come in and introduce it and push it in a way, that's very important. The other thing is this perception of VR as entertainment. This was something that was very apparent when people associated the VR experience with sort of a TV-like experience, like this is just to take my mind off of it. I think the word distraction, we need to move beyond the concept of distraction. We need to talk about activation, because the real benefit of this technology is not distraction, it's activation. It's what they are doing when they are in VR. And it's not just like watching the TV. So that's sort of a different talk. But in terms of doing this, we want to lower the barrier to use. They have to be able to use it fast, and also we want to be able to have them have some therapeutic benefit and understand that therapeutic benefit. So I will just kind of move on to encouraging signs. In conclusion, so we are seeing a real increase in strong proof points, not just in our software, but other software that's being reported here. Opioids continue to gather public attention and demand solutions. Baby boomers are looming, so we all are familiar with the freight train that's going to come, and healthcare is ripe, looking for solutions. Reimbursement has started. We have multiple ways that people are getting that doctors are getting reimbursed for our software. One is biofeedback, mindfulness, skills training, rehab, sort of psychotherapy, and they're able to do it. And what's really exciting is that payers are finally getting on board. We have a lot of those discussions. Payers are actually starting to want to initiate their own studies. So I think the future is bright, and I will conclude there. Thank you very much.